Okie dokie. Hello, everybody, and happy end of July. It's hot as holy you know what everywhere. We were just talking about that, so I hope everybody's staying cool. It's very hot in Jersey and everywhere else. I do appreciate you guys all being here tonight. We have a couple of guest speakers. One, Dr. Bowers is going to be sharing her experience with microclotting, and Dr. Jordan Vaughn in Alabama is going to discuss findings and a whole bunch of good stuff. So I'm going to say my spiel, and then I'm going to hand it over to Angela. Are you going to talk first, or is Jordan going to talk first?
Yes, I think I'm going to just give a brief overview of my experience, and then he'll kind of go through all the science behind it.
Okay, perfect. So React 19 is a science-based nonprofit offering financial, physical, emotional support to those suffering from long-term COVID-19 vaccine adverse events globally. Our mission is to bring healing to the moms, dads, friends, and loved ones who are facing life-altering side effects from their COVID-19 vaccine. We build bridges between patients and research institutions in order to develop a better understanding of our vaccine complications. So thank you all for being here. So I'm going to just get started here. Dr. Angela Bowers, she is a board certified dermatologist in Dallas, Texas. She received her undergraduate degree at Texas A&M, summa cum laude. She completed medical school with honors at University of Texas Southwestern Medical School in Dallas, went on for her internship at Baylor University Medical Center in Dallas, and completed her derm residency training at UT Southwestern and was chief resident in her final year. A real slacker, Dr. Bowers.
Yeah.
Past president of the Dallas Dermatological Society, and she received some vaccines and has and is going to tell us about it. And then I guess I'll just, whenever you're done, then I'll introduce Jordan and we'll get going. Thank you.
Yeah, perfect. Well, I was one of the ones that was just, as soon as I could get the vaccine, I was, all on board, and I still am kind of pro-vaccine, but I had the unfortunate event happen where I had the first shot like December 2020, I guess it was, when it was first coming out. And then the second one was in January. I didn't actually have any response much from it, just sore arm. I didn't have any of the fever, chills, these things that some people have. And then about a week after the second shot, I noticed that I started having some paresthesias in my hands and my feet. And then I had kind of this really bizarre kind of muscle rigidity, almost a cogwheel type of shake to my muscles that is still actually happening for, the last 18 months. I've continued to kind of have this muscle issue from it. So as a background, very healthy, 52 at the time, I guess, exercised, was been very kind of blessed with good health until the vaccine, and started having kind of the usual, like up and down tachycardia, fatigue. Like I thought I had multiple sclerosis. So I was being seen by, neurologists, and I went to the medical center. So to make a long story short, they kind of diagnosed me with small fiber neuropathy. I did have a biopsy done that showed low normal. And by that summer, I had quite significant neuropathy in my fingers and feet, not real painful, but just, hard time really texting. That probably is what affected me the most. And of course, in my job, I do a lot of procedures with my hands. So it was, medical history really pretty healthy, except I do have factor V Leiden mutation, which has never really given me an issue. I haven't had to be on any kind of medicine for it. Just had to be, when I was pregnant, it had to be prophylaxed. So around November, I ran across Dr. Pretorius' study and reached out to her, and she was kind enough to email me back and give me kind of what she had happened to her with the vaccine and about the microclotting. She had noted that they have been able to see some of the little microclots under the microscope. So I actually went and had that TEG, that thromboelastogram done, which was kind of very at the end of normal for being hypercoagulable. And then I drew my blood. I have a centrifuge at my office because we do PRP, for some different procedures. So I was able to, had the supplies at my office, thankfully, took my blood, spun it down, put it on a slide. And sure enough, I could see these little microclots that look very much under the light microscope like it did with the amyloid immunofluorescence that Dr. Pretorius has published. So sent her pictures, was able to get a little picture through the microscope after 10 or 15 minutes of intense effort with my iPhone. And she confirmed that that's kind of what they see also when they just see the same specimen under a light microscope. So then I ended up starting on Plavix and aspirin. And at the time, it's November. It's still pretty warm in Texas in November. I was having to carry around like hand warmers at work because my fingers were just, getting more purpley and uncomfortable. So about 3 days after I started Plavix and aspirin, I had a noticeable difference in my brain fog. I was having a lot of trouble pulling out words, really becoming kind of apathetic, like this very depressed, apathetic type of mental fatigue, I guess you'd have it. And about 3 days after I started the Plavix and aspirin, it was like night and day, with like shockingly night and day. And then I added Eliquis to my routine about 5 days after that. So I had, trying to get my hands on Eliquis was a little tricky. But I did do triple therapy for a month. And then I felt like I was, kind of healed. I mean, minus my muscle thing was still kind of happening, or still happening. But then what's interesting is I did finally get COVID. I never had COVID through any of this. Finally got COVID with the Omicron that came through, and was on aspirin and Plavix at that time. I had already stopped my Eliquis, and I had a pretty uneventful course with Omicron. But about a week after, I started to have the crash happen with the fatigue and that whole like long COVID type of symptoms, which I'm still battling. But I added Eliquis back for about a month and didn't really seem to help, like the mental fog type of thing. So it was a little bit different. But I can definitely tell you this microclotting thing, it's so real. I mean, it was just remarkable the change that I had from trying to just get some blood going through my vessels again. So that's really kind of my story. I'm about to recheck my blood again. I did look at it again after I'd been on some treatment, and I didn't see as many clots. Actually, kind of sent those pictures back over to Dr. Pretorius as well. And meanwhile, I have seen several patients that have some similar histories. We see a lot of, different skin manifestations with COVID, and we've been able to help, a few of them, not anywhere like Dr. Vaughn has been able to do, but it's quite interesting. And I know we don't all know the whole story yet, but I'll lean it over to Dr. Vaughn because he's done some amazing stuff and saved a lot of lives where he's at.
All right, cool. Thank you. I'm going to introduce Jordan Vaughn. Dr. Vaughn is in Alabama. He received his bachelor's in chemical engineering from University of Alabama, medical degree from UAB Medical School, and completed his residency in internal medicine at UAB Hospital. He's the son of a local physician, Dr. Michael Vaughn, who started MedHelp Urgent Care in 1982. And that's when Jordan was born. After finishing training, Jordan brought his knowledge of internal medicine to further help expand the MedHelp clinics to care for patients in all aspects of outpatient care, acute and chronic, body and spirit. MedHelps have 6 locations and see over 180,000 patients a year. Since the appearance of SARS-CoV-2 as owner and CEO, Jordan has pushed his organization to be leading edge of properly delivering early outpatient treatment for his patients in the Birmingham community for COVID-19. And I was impressed with Dr. Vaughn. I was on a call with concerneddoctors.org, the organization in Alabama for medical freedom. And he started talking about the microclotting, and I had asked him at that time if he could speak. So he has agreed, and I do appreciate it very much. So Jordan, I'm going to turn over to you.
Okay, can everybody hear me? All right. So what I want to do first of all is thank Angela actually, and Angel. I was reading and doing what Risa Pretorius and Doug Kell, as well as Jaco Lobsher, had really put in the literature. And it was actually Angel connecting me with Angela. And then we were able to actually, I think, start something great going forward. And I'm very hopeful that we're going to be able to do what I would call a spike protein injury clinic here in Birmingham and do a randomized controlled trial. It's got to be kind of generic like that, as opposed to vaccine injury, because I can't really get state funding in any other way. But what I'm going to do is share my screen, make sure everybody can see it. Actually, I've never shared my. Do y'all see? Let's see. Can everyone see that?
You're good.
Okay, so basically what my biggest goal is, and there's actually been two recent papers, actually Risa and was in Science, the Science magazine, which is becoming pretty mainstream. It was also in Hematology Advisor pretty recently. So at least the hematologists are starting to understand that this is something that needs to be looked at. And really the reality is what I've learned in acute COVID was that at the end of the day, the real problem is the vascular system. For the most part, it became the patients that got hypoxemic, patients that had issues. And I will tell you the first, probably the January, February of 2021, when I started to see some patients that had shortness of breath, didn't have COVID, but had just recently been vaccinated, started to see their blood work, started to see their D-dimer, started to see their coagulation factors, got CT angio. CT angios were otherwise normal. This is when this all started to make sense that, oh my gosh, this is a very different kind of mechanism in this spike protein itself, whether from the disease or from the vaccine. In people that especially have underlying coagulation issues, it's something that we shouldn't be messing around with. And I think that's one of the most important things to say. So one thing I wanted to do is go ahead and play 2 minutes of Jaco's video. A lot of y'all don't know who he is, but I would say this guy, a private practice cardiologist and intensivist in South Africa, posted this YouTube video in June of 8th, 2020. And I'm just going to go ahead and let y'all listen to it. But what he says is prescient, but it also shows you that it doesn't take what I would call a Soviet commissar up in Washington telling us what diseases are doing. So let me go ahead and play this.
Good evening. My name is Jaco Lobsher. I'm a physician in private practice at the Stellenbosch Clinic in South Africa. I'm here today to try and convince you that the management of COVID-19 is an important factor and we should stop barking up the wrong tree. This is a vascular problem and not a respiratory problem. Tonight, I'm going to try and convince you of that fact and hopefully equip you better to save lives. All over the world, reports were found that there's some anomalies regarding these patients. Patients become severely hypoxic despite having normal lung compliance. Increased reports of thrombotic complications in spite of therapeutic anticoagulation, usually using heparins or low molecular weight heparins. And poor outcome of patients that progress to full ARDS despite optimal therapy. Consistent finding of thrombi in the microcirculation of the lung on post-mortem studies. If we look at the elementary functional unit of the lung, it's basically an alveolus and a blood capillary, and that's where gas exchange happens. So if you look at these patients clinically, you listen to the lungs, there's actually not much sounds to be heard. The patients have got a normal mechanism of breathing, and early on when patients are being ventilated all over, intensivists would tell you this is hot. The patient's ventilation is actually quite easy, normal lung compliance. So from that we can deduct the compliance of the lung, the alveolus, is normal. So if the patient is severely hypoxic, the only thing left is the vasculature. So you've got a blocked blood vessel proven on post-mortem studies, and that's why the patients become hypoxic.
So,
So
oh, sorry. Okay, we're gonna go back here. So the other people I want to thank are really Risa. And so Risa actually is who Angela talks to, who also evaluated, I think, Angela's blood through an iPhone remotely. So she's a pretty amazing person. But her history was trying to really figure out clotting issues in chronic disease states. And so, again, a good example would be she was trying to figure out why diabetics have strokes. We know statistically they're higher to have strokes, but the question would be why. And so what her history was looking at was these hyperactivated platelets and these abnormalities in the coagulation system in chronic diseases. And actually how it happened was Jaco started seeing this stuff, and he knew Risa, and he sent blood to Risa to start being evaluated. And Risa looked at it and said she had never seen anything like it. And I think that was the start of this understanding that there is something going on here that's more than just, it's not just a viral pneumonia. The other guy that actually put a lot of this together is Doug Kell. He actually has more initials after his name than I think I have in my name. One of them means he's like knighted by the Queen or something. So this guy is a head of biological science at University of Liverpool, but really one of the most amazing guys doing kind of systems biological research. And he's also been working with Risa. So again, it's a private practice cardiologist, intensivist, and two bench scientists that really have really come upon something pretty amazing. So again, my overview is kind of COVID-19 as an endothelial and vascular disease. So it's not new. I would argue actually some of the articles would say that, we need to stop we at the beginning treated this like it was a viral pneumonia with the side effect of having DIC at the end. But what really is happening is this is an endothelial and vascular issue. And that's really what's accepted really in the pathological realm, as well as at the bench. But I will tell you, not to embarrass my city, but if you go downtown to UAB right now and ask any physician, is COVID-19 a vascular disease? They don't even know what you're talking about. Okay. And this has huge implications, not only from the vaccine side and treating microclots from the vaccine, but also treating people that have long COVID. And why I call it a spike protein injury clinic in the future is because at this point, pretty much everybody that's vaccinated has also had COVID. So it's kind of becomes just a mix of both. Okay. The other thing is what surprises me about this idea is it's not like it's being kept away, meaning like it's not like these academic centers aren't looking into it. I mean, the top cardiologist at Harvard wrote a paper that says basically that COVID-19 is a vascular disease. But again, this is not being mentioned anywhere, and it really is inhibiting the ability to take care of people. I'll tell you, I had somebody the other day, 78 and 79-year-old, both had COVID also all of double boosted and post Paxlovid. And one of them came in with a leg drop as well as a facial drop. Well, of course, he's had a stroke in the context of his disease, but treating him as if not only did he have a stroke, but the stroke was related to the procoagulant state or prothrombotic state of COVID. He actually sent me a video Saturday and he's back walking. Okay. So again, a lot of these strokes that are happening, if we treated the disease as if it's a vascular disease, we would be able to, actually treat it effectively. Instead, most people think a stroke has nothing to do with COVID. And in reality, you can't not treat it as part. I mean, you have to treat it as part of the disease. So what he basically was doing, this is a little bit better graphic of what's going on. But I mean, we're talking about basically the normal alveolus versus the injured one. And what the big, issue is that what's really causing the disease process in both the long COVID, acute COVID, as well as probably is vaccine injury, is that what's being blocked off is the microvasculature. A lot of pulmonologists sit there and they'll say, you don't have pneumonia, your lungs sound good, you're breathing in and out, but the patient will be like, but I'm hypoxic. I can't, I can't breathe. I feel short of breath, but the reality is what's actually happening is you can move air in and out, but the air has to be able to deliver, or the oxygen has to be delivered to the microvasculature. And if there's clots in the microvasculature, and not only those clots, and we'll talk about it in a second, they're not just regular clots. And that's what's so unique about the S1 subunit of the spike protein. So how I look at kind of the coagulation properties of the disease is I look at the early stage. And again, we're looking at labs that, you start to see this hypercoagulability, especially in people that have an underlying coagulation issue, which, by the way, is a lot more common than people think it is. And actually, it's a lot more common in men. Most men die never knowing they have an abnormality, but about 10% of people have one of these. And it seems like this is the event that all of a sudden showed them that it was a significant issue. Otherwise, most men, outside of some massive trauma, women a lot of times will find out around the time that they're pregnant. And around that time, they might have miscarriages, they might be put on aspirin, so they have von Willebrand's disease or factor V Leiden. And so women sometimes do know that they have a coagulation issue. Men, they never really find out until they have some massive, hospitalization or something like that. But this is how I really look at it. Again, the disease progression is really brought on by the immune system activating the coagulation system, which ultimately leads to hypoxia. Now, what I will say is when you look at the C stage, I have had patients that at the end, they do get, they do start to bleed. Okay. And the reason is that because they've used up their von Willebrand's factor and their other fibrinogen. So basically it's not because it's not a typical DIC. Instead, they're basically been spent of all the things that they need to make new clots. And so it's like, it's like clotting gone awry when now the factories don't even have the basic things. It's like I guess President Biden's supply chain issue. At the end here, it becomes a problem. So what they've given the name to a lot of this is that COVID associated coagulopathy. And this is just a really fancy slide, and we can talk about it later, but I really don't even want to talk about it. But you can see what Angela or what other people have been talking about is this thromboelastography. I don't use that in the clinic. And what I'm going to talk about is how I'm hopeful that what we can do is come up with some surrogates within the clinic to better define this, because a lot of times what's the issue is a lot of these labs are labs that you need to have in a hospital setting, and they're really hard to do in the clinical setting, especially when you're talking about vaccine injuries or you're talking about somebody with long COVID. And for the most part, I mean, a lot of the people that come in, they might be 19, 20-year-olds, like I see 19, 20-year-olds college athletes that they had COVID. And since then, their mile time is like half of what it was. I mean, they have no other reason. I mean, it's COVID-19 is causing this issue. So it's not like, but as you get into the older realm of older people, you start to have issues with a lot of kind of parsing what is a chronic disease and what isn't. But the interesting thing about this is how Jaco and Risa came to understand that spike protein injury also caused really long COVID. Was Jaco was able to do TEG in his acute patients. And when he did that, he started them on triple therapy, literally day 3, 4, 5. Okay. Out of the 300 that he did, not one of them had persistent COVID symptoms. Okay. And so trying to figure out why that was, he was talking to Risa because everyone else seemed to have persistent COVID symptoms. Okay. And what was found was that the people that were treated under Jaco, their blood was fine. And the people that weren't, it wasn't. And the only difference was that Jaco was treating them as if they had, the hyperactivated platelets in a hyperactivated coagulation system. And that's how Risa came to realize that, hey, long COVID is probably explained by this too. And so go ahead and say acute COVID-19 vascular. We've all seen this, and I think Dr. McCullough this is actually what I give all my patients when they come in and we talk about what the disease process is. And it kind of explains it, again, the viral proliferation, the cytokine injury, and the thrombosis. But what I have now realized is that thrombotic issue, even if the patient doesn't get hypoxic in the acute stage, it's something you've got to watch for, because if they don't do that, but they have severe disease and what I would call COVID pneumonia, where you have the vascular changes in the lung, they're going to be back in 3 months saying, I've never gotten better. Okay. And so addressing it early really does matter. And so one of the things that we've done in our clinic is, you get treated for the viral proliferation with monoclonal antibodies or whatever the antivirals are. We also make sure you get treated with immunosuppressants or corticosteroids and immunomodulators. But you also come back day 5, 6, we do your D-dimer, we get a chest x-ray, we check your blood for evidence of hyperactivated platelets. And if there is that, we go ahead and start it then. We don't wait for them to come back hypoxic. So, again, Jaco's already talked about this, but the one thing that other interesting fact is this is a study out of Italy. And what they did is they had 11-year-olds that continued to have persistent symptoms. And those persistent symptoms, the pulmonologist and all the cardiologists said, look, everything looks normal. Okay. And I think one of the kids' fathers was a physician and said, no, I know my kid there's something different about them. And what they did was they did a SPECT CT, which actually combines a CT scan with perfusion. And what you can see here is even though the CT scans on these 2 images look completely normal and your pulmonologist would read it as normal, what you can see is there's a significant perfusion defect. And that is what they're feeling. Okay, so we're talking about people that even though their chest x-ray and CT scan look okay, or maybe just has little changes, where the microvasculature is impaired. And that means that they are going to not have the same reserve and oxygen delivery that they had previously. And so that this is kind of corroborates what Risa was doing, but this is a guy in some studies in Italy that came out that again kind of contribute to that. And I'm just pointing out the little areas again. I mean, these defects, there's an obvious defect in the perfusions of these scans. And when you put them on top of each other, you see that in 11-year-old's lung, that should all be red. Okay. And it's not. So the vascular hypothesis treatment implications is the management of that hypercoagulable state. And what really it means is therapeutic blocking of enzymatic pathway of coagulation is needed, therapeutic blockade of platelets with antiplatelet therapy, and then addressing that VQ mismatch with pulmonary vasodilators. Now, I don't use vasodilators that often. I only use it when they're really hypoxic or really bad, but it's a way to actually move. It's kind of a steal phenomenon where you take the blood from areas that aren't being vented, or that you don't want blood running across in areas that are open, I guess is what I'll call. So next is what Doug and Risa really did is this paper to me is foundational to my understanding, okay, which is SARS-CoV-2 spike protein S1. And again, they didn't say vaccine. They just said the S1 subunit of the spike protein induces fibrin resistant to fibrinolysis, okay? And so what that really means to me is, okay, not only, so they took recombinant spike protein and dropped it in platelet poor plasma, okay? And they didn't need thrombin. They literally, in that B photograph, they just dropped the spike protein itself, the very thing that we have given to 2 billion people to make unopposed in healthy individuals, meaning, which is scary, right? And what that spike protein does is instantly cause fibrin chains and hyperactivation. And so this is, again, microfluorescence of that. So again, the top right is the healthy platelet poor plasma with recombinant spike protein dropped in. C is healthy platelet poor plasma plus thrombin. Classically, to actually form these fibrin chains, you need thrombin. You don't need thrombin if the spike protein does it itself. That's insane. And so now the healthy platelet poor plasma with thrombin, then you add the spike protein and it goes even more haywire. So again, the one reason I think that there's probably not that much interest in going down this direction is because of what this begs the question of, which is if this is what happens with the S1 subunit of the spike protein, why are we not screening for people that have coagulopathies? And why, first of all, we can get into it later, but the nucleoprotein actually offers better, there's a Cell paper from June of 2021 that actually shows that the nucleoproteins is really what offers long-term cellular protection. But so why haven't we changed to a protein with this technology that actually is not damaging? But why are we using a protein that by itself can cause fibrin to basically form? And not only when it forms, it's resistant. It's very hard for it to break down. So again, this is one of the papers that I send to all physicians when they go, what the heck are you doing? And when they read through this, they go, usually there's a little bit of a, like a light bulb goes on and goes, well, this means, and I'm saying, and I usually say exactly what you're thinking is what it means. So, so again, what RISA did in the past was looked at why type 2 diabetes had these issues. Okay. And so again, this is the same kind of structural changes in fibrin that happen, but you can tell the difference between type 2 diabetes plasma, which is an issue and would cause clotting issues, but compare that to COVID-19 plasma. And it's just absolutely nuts. Okay. And again, we go back to microclots in healthy participant versus acute COVID-19 versus long COVID. So you can see in the acute phase, they're a little bit, they can be long, but in the long phase, they continue. They don't break down. They're resistant to fibrinolysis. So to me, that's the big issue. And that's, again, when we talk about platelet and clotting pathologies, we'll have not only issues with on the microfluorescence, but she actually did electron microscopy. And basically what that shows is the structural changes. And not only that, if you look down here at these red blood cells, there's actually microclots connecting red blood cells. Okay. So, again, this is just crazy. So it's just fascinating. First of all, it's fascinating that we can look at this level, but if you know what regular activation of white blood cells, red blood cells, and microclots are, this is very abnormal. And this is what leads to the disease itself to be so, what I would call different. And one of the things I've had an issue with the medical community is a lot of what we do as physicians is we hear symptoms and we try to fit it in diseases we know about. The problem is, I think a lot of physicians are missing is, this isn't something we know about. This is unlike anything we've seen. So if you don't really understand, if you're treating it like a viral pneumonia, you're going to miss this. And you're not going to realize that stroke that happens within the 10 days of COVID is really COVID stroke. It's not, it is a stroke, but it's a COVID stroke and you need to treat it as such. And I think instead of sending to a neurologist or they feel short of breath, sending them to a pulmonologist, it's just a fundamental understanding that says this is a vascular issue, and the vascular compromise and the vascular, what I call microcirculation issues, is really what explains so many, not only vaccine injury symptoms, like had a lady today that had the craziest COVID toes I've ever seen. Tried everything, but we will, I think pretty soon, one of the neurologists here that works with me, she sent her over to me to do triple therapy. But again, the COVID toes is a vascular phenomenon. Okay. And so again, we're missing a lot of stuff. If we don't understand fundamentally that at the microcirculatory level, that there is likely fibrin deposition, and it's fibrin deposition that blocks off, what I would say is, who cares if the train is loaded with oxygen, meaning your red blood cells or your hemoglobin? Who cares if it's loaded if it can't deliver it? Okay. And if it can't deliver it, you're going to have a lot of trouble. So the other thing she did is set up a microfluidic environment. And a lot of this is from that original paper. But what this is basically healthy platelet poor plasma that she put through a microfluidic environment where the tubes are actually made of thrombin. And what you can tell on the healthy platelet poor plasma, when she actually pushes it through, what you get is a little bit of clotting, which you should get because there is platelets and moving through the air. In COVID-19, what you get is these nasty, long fibrinic chains that are, again, very abnormal. And actually, we'll talk in a second, they're amyloid. When they stain, actually Doug, for some reason, decided to stain them for amyloid, and they stained for amyloid, okay? This is what the spike protein does. So again, COVID-19 causes these long, weird, so again, the spike protein in COVID-19 is a little bit different than the spike protein that's in the vaccine. But again, they cause the same accumulation of really abnormal clotting pathologies. So with this, Jaco and RISA decided to do kind of a South African long COVID registry. And what they started to do is just get a lot of complaints from patients and kind of put things together. The thing that really did probably matter too was, not surprisingly, diabetes. As we showed earlier, diabetes seems to already have hyperactivated platelets and abnormal clotting pathology. So you add spike protein or COVID-19 to the mix, you're going to get a disaster. So again, and then they tried to break down kind of the long COVID manifestations to its effects. And those causes, again, persistent virus antigens, T cell abnormalities, but most of them below that, you're talking about mainly vascular issues. And most of the effects of this can be kind of uniformly put through to be explained by a lack of oxygen, from brain fog to my favorite term right now among cardiologists is, well, it's POTS without the P. Well, I'm like, well, if it doesn't have the P, is it really POTS? I mean, it sounds like a tachycardic syndrome that's new that isn't in the book. We need to probably, explore it as a different phenomenon. But the other thing that Doug is really active on, the post-exertional malaise, is he's kind of come to the point that he thinks it's probably a chronic reperfusion injury, or what I would call that basically that blood gets there, but then the cells don't get enough oxygen from that blood. And then you get that kind of death cycle of cells that release a lot of inflammatory issues. So that's why people hurt after they've been doing stuff. It's like they try to do stuff, they feel okay, but then very quickly they get that post-exertional malaise. Again, platelet ultra structure. These are some cool micrographs from them as well. But again, healthy individuals versus individuals with long COVID. I mean, these are just, it's different. The other thing they did is they said, okay, we're seeing these people in long COVID or spike protein. We see when we look at their plasma, they actually did a digestive step where they basically squirted trypsin over them to see if they break down. And again, this goes to their proving that these are resistant to fibrinolysis. So regardless, let's see. I like to give this to all my patients when we're talking about kind of both a acute COVID event. To me, also could be a vaccine that went haywire, but it's that basically that fibrinogen interacting with the spike protein that creates amyloid fibrin microclots. Most people, if you were to do it in the acute phase, actually I have a girl right now that just got her mRNA vaccine, and her D-dimer is a psycho. Like literally, I mean, she got it 3 days ago. Or 3 days, she got it the day before we did her blood, and then we did her blood again, and her D-dimer is still elevated a week later. So there's an active coagulation issue going on with her. So again, some people have healthy fibrinolysis, meaning they have their interaction with the spike protein. It causes their body to make this fibrin microclot. Most people break it down, okay, but everybody makes it, which is kind of crazy. But the people that have failed fibrinolysis, and a lot of those people are people that already have some genetic, what I would call genetic predisposition, probably like Angela said, she had, was it factor V? So, a lot of the people that I've talking to, and I don't do genetics on them, but when I kind of parse down to, talk to them about issues they've had with, whether it's menstruation or pregnancy or those kind of things, it's interesting to find that a good bit of them have had that issue, or they had issues with miscarriages, those kind of things. So it's not surprising to me that there's some genetic predisposition. We just don't know what that is yet, but I think it's definitely going to be in the realm of those 10% of people that have some coagulation issue. So this is another crazy diagram, but for the most part, this explains a lot for what I'm looking at. And again, what I'm always trying to do with patients is get them to understand what's going on. And again, you could fibrin amyloid microclots. I mean, you can put that for COVID. You can put that for the spike protein. We know that spike protein makes it. We know that COVID also makes it. I feel at this point, pretty much everybody's had both. There's not that many people left that haven't had COVID, but I do know that if you've had COVID and got really bad long COVID, then you get vaccinated, then you're definitely on your way into my clinic pretty quickly. So it makes it that much worse. I actually think one of the contraindications for this vaccine was, were you hospitalized with COVID? That should be, that you should never be allowed to even touch it. So, because it's all I see is it causes just extensive worsening damage of their issues that are already present. So again, the blockage of those microcapillaries that causes low oxygen carrying capacity, it causes both tissue dysfunction as well as cellular dysfunction. Cellular dysfunction, including mitochondria, is what causes a lot of the brain fog, kind of concentration issues. Tissue dysfunction is more the breathlessness, fatigue, myalgias, and the tachycardic syndrome. So consequences of microcapillary blockage by microclots, from whether it's spike protein from COVID-19 or the vaccine, is red blood cells can't penetrate the tissues. You get ischemia, you get hypoxia, you get fatigue, you get damage to any tissue undergoing hypoxia, and really get this ischemic reperfusion injury that causes a lot of pain everywhere. So what Jaco and Risa did was they said, okay, well, Jaco's treatment worked in the acute phase, and we're seeing the same changes in people in the chronic phase. What they did is said, well, let's see if it works in the chronic phase for people with persistent symptoms after COVID. And in all honesty, it also, as Angela says, it works in people with persistent symptoms from a vaccine injury, especially the vascular symptoms, whether it's the COVID type toes or the lack of blood supply getting the tissues. And crazy enough, there's actually, I don't know, there's a patient from one of my colleagues that there's a rheumatoid arthritis drug that actually they're called JAK inhibitors. And those JAK inhibitors actually are prothrombotic. And so it seems like having vaccination plus a JAK inhibitor, you might as well, in this case, have your finger, you may not want your finger, meaning in the end, it caused some significant damage because again, they kind of in a loop cause significant issues. So so this is what they did. This is their protocol. And this is what I really want to do. And I'm planning on doing with Doug and Risa and we would do what we would call a crossover trial. We would do it probably for long COVID, but the nice thing about this treatment is it also works for spike protein. Because again, if at the core, the endothelial dysfunction and the clotting issues are from the spike protein, the vaccine injuries, at least the clotting issues of the vaccine injuries are treated by this as well. So what they did was said, if it's large scale endothelial dysfunction and tissue hypoxia, and you'll see up there, the classic symptoms, but in red says, it seems like there's this underlying genetic predisposition. Okay. I think that's diabetes is one of those things, but also I think a lot of these are those hypercoagulable genetic traits. Weird enough, I've got some families and it seems like the grandmother, the mother, and the daughter, if the grandmother has really bad COVID and needs anticoagulation, it seems like the daughter needs it too when she gets COVID. And it's again, this is all anecdotal. I'm not telling you that but it seems to run in families, which usually is kind of the first suggestion that there might be a genetic component to this. So so what they did was basically put people on dual platelets, and that it's a weird thing that you need both antiplatelet agents, but they put the dual antiplatelet agents are an aspirin to deacetylate platelets and Plavix, and then you got to put at least one direct oral anticoagulant, which would be Eliquis or Xarelto. Weird enough, one of my colleagues actually today was asking about Pradaxa, but I mean, it would seem that it would work too, but that's an antithrombin agent, not a factor 10A inhibitor. And so you also, the worst thing that can happen during this, obviously, is in a young person, it's skydiving. And the older person, it's falling. But so for the most part, a lot of the people that I've picked initially, and it was easy to do on, were people that have really no risk for some type of hemorrhagic bleed or some really bad fall. And so those would be like college swimmers, college athletes, runners, those kind of people. And they have had incredible success. It's usually very rapid success in the young people. In the older individuals, it usually takes a little longer. And I also have to really factor in their underlying comorbidities and, even depending on the age, I might get an MRI to make sure that there's no hemorrhagic issue or any susceptibility to that kind of stuff. So you just take it a little bit with a little bit more caution. The way I look at it is, it's like the young people are like a brand new hose you get at Home Depot, and the old people are like you left that hose out in the sun for 2 years. So, the hose that you left out in the sun for 2 years, when you put water through it, might bust. So that's kind of what I do. So basically, they did this, and in their trial, which is about 100 people, 100% of the people had resolution of their primary symptom. Okay. Again, they picked people that pretty much all they had was post-COVID symptoms, and prior to COVID were otherwise healthy. But it's a pretty dang good evidence that what's going on seems to all be related to local tissue hypoxia, meaning the actual, again, the train might be being loaded, but it's not being, it's never arriving at the station. And so again, you got to clear off the tracks to allow it to be delivered to the station is kind of a metaphor. Let's see what and then this is a representation in their study of before and after. Okay, so before their treatment, and then a month after, their blood smears are significantly different. So so going forward, again, I'm hopeful, and actually working with RISA to get, and the grant that I'm working on here, that I will have all the stuff to be able, and actually RISA is probably going to fly over and leave me a grad student, but not everybody can do that. And so what I'm trying to do with them is, if we do this, how do we have an easy clinical surrogate, whether that's a blood test like D-dimer von Willebrand's factor, or whether it's some radiographic study. I mean, it would be nice. I was talking to my radiology friend today. I was like, how hard is it to get a CT spec CT? Because that'd be great. We could find out if people have lung defects, and that'd be pretty easy to diagnose. But it's, again, a lot of these are done in the hospital. So what I typically have done, and this is just somebody who's I've seen, and again, this is a typical 40-year-old that came to me. He got COVID in March of 2021, and he had literally been through the ringer at an academic medical center to every neurologist, pulmonologist, cardiologist, whatever. And all of them had different answers that made no sense, and none of them did a damn thing. Okay. And he was literally leaving his high profile law firm job and deciding that he was going to go on disability. And his wife, who's pregnant at the time, walks into the clinic and says, I heard your name at church. What can you do? Okay. So again, I just had digested a lot of these papers, had been doing some stuff. Obviously, in acute COVID, I've been using anticoagulants a lot with really good success. And I will say, everyone that I pulled out of hospital, so something that I've done is I've actually unfortunately gone to battle with the hospital here, but if they're not giving them full anticoagulant, I'm pulling them out of the hospital and putting them on oxygen. I don't want them anywhere near a ventilator. If they need to be in the hospital, they need to be on ECMO. Otherwise, they don't need to be in the damn hospital. So that is what I have done. And what I found among those people was their chest x-rays were always better than people that really never got that bad. Okay. And so that's one of the things that really made me kind of unify my understanding anecdotally with what RISA, Doug, and even Jaco were seeing and actually proving. And this is a good example. I mean, within 3 months, okay, again, what I will say is this triple therapy on somebody who's had COVID a year ago or more than a year ago, it takes a little longer, okay? But you can see on the left, this is a year out from COVID. A pulmonologist would probably look at this and say, oh, yeah, that'll get better. Well, it's been 13 months, buddy. It's not better, okay? You put them on, and what we know about in the literature is the ground glass opacities and a lot of these interstitial changes, what they are fibrin, okay? And so you put somebody on triple therapy, and in 3 months, that's what their chest x-ray looks like, okay? Again, it's broken down all this crap. Not only that, he's back at work, he's sleeping normally, and he's, not, basically getting to have fun with his new baby, okay? I mean, this is what's going on in the world. And I will say, the people that come to me, at least initially, most of those people were people that were college runners or highly active, no other issue, college swimmers, highly active, highly, fit lawyers, those kind of people, that they literally are tired of being told that it's something else when they know they had COVID or they got vaccinated and they haven't been the same since. Okay. Those people are easy to pick out. The harder are the people that were tired to begin with. And so that's where parsing that stuff is an issue. So, and again, when I talk about that, why I use the chest x-ray as a clinical surrogate, I'm not suggesting that you use it. It's just one of the things that I use, is that we do know that, these extensive opacities, as well as that post-mortem, is basically fibrin. And actually Doug's trying to get it. Not only that, he's trying to stain it for amyloid, because right now we definitely know it's fibrin, but I'm pretty sure he probably assumes as well as knows that he hasn't found anybody that's actually stained it for amyloid, but when they stain it, it's probably going to stain for amyloid, which means it's very hard to break down. So the silver lining that I have seen is I think Doug and Risa actually went back to their pool of ME and CFS patients. And among those people, it seems like their issues are some abnormal clotting issues, hyperactivated platelets, and basically abnormal coagulation cascade. And I really think if you look at what Risa's got going on, I mean, she's looked at Parkinson's disease, diabetes, all these things. And I mean, if I would say the last 20 years have been the inflammation, in medicine, honestly, I think it might be how inflammation impacts clotting might be the next 10 years. I think it is really, and it's kind of a silver lining of COVID that we really are kind of, I think, on the kind of precipice of learning a lot about how to take care of chronic diseases and how they relate to microcirculation and what I would call microclots. So again, that's just hopeful talk. But anyway, that's pretty much all I have. But it really, yeah.
Well, I was going to suggest whenever you're done with your slides, I can share my screen and just show what I had seen in under the light microscope of these little microclots for people to see.
Yeah, go for it. Yeah, that'd be awesome. Go ahead.
Okay.
You should be able to share it now.
So can you guys see this? So this is basically, I took a picture out of one of her papers. I don't remember which one. And then I did spun it down like she told me for 15 minutes in a sodium citrate tube. And you can see my microclots here look very similar to what they were seeing under their light microscope. So, that was, and I actually had some suggestion. Let me see if can you guys see this, the inflammatory labs? Is that popping up? No, okay. Let me
you switch your screens probably.
Yeah, let me get out of that. Say, okay, let me hit share screen again. This was my TEG profile. Is that popping up for y'all?
Yeah.
Okay. So you can see I was at the outer edge here. If y'all remember that, what he showed those two diagrams of
thromboelastography. Yeah.
Exactly. Okay. And then this was kind of my clue where I knew something was going wrong when I had my labs checked by Dr. Patterson. Of course, everybody has different views about some of his thoughts on that, but it was very helpful for me to at least feel like I'm not nuts. Okay, did that come through at all with the lab work?
Yeah.
Let's see. Oh, geez.
Yeah, and
okay, here we go.
that SCD40L as well as yours VGF wasn't high, but anyway, that
right, my VGF wasn't high, but you can see like 8, 10 these platelet activated interleukins, and then that CD40L. Of course, I had to look all this up. We use different, things in dermatology than these, and it's like something is wrong. So I started kind of putting all that together. I was just so thankful for Dr. Pretorius for getting back. And then I'll stop my screen share here. But Jocko also met with me like 15 minutes and basically said, okay, do this, 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 and this. And then, couldn't get any help from my alma mater, really, of multiple specialists. But I mean, it is hard. It's a new thing. So hopefully we're starting to make a dent on people getting treatment.
Yeah, my biggest thing, Angela, is physicians were very good at fitting symptoms into diseases we know. I don't think many of us have ever been we really, outside of maybe somebody on, some kind of, African continent, trip, we're, to see a new disease and see how, we're not trained to do that. And you've got to have an open mind. And I think that's really what's missing from our system is they've kind of closed the door and built a box around something that literally is brand new. Okay.
Yeah.
What that's the last. First of all, you might want to build a box around something that we've known about for 50 years, but even then you probably don't want to. You still want to be able to get outside that box. But to build a box around something that you've only known about for a year, that's the dumbest thing you can ever do.
Yeah. Yeah.
Thank you so much. Thank you. Jordan, that was awesome. There's a question. We have a hand raised and there's a couple of comments in the chat. So Philip's iPhone.
Hey, thank you. Jordan, can y'all hear me?
Yeah, I can hear you.
Okay. Yeah, I just want to pass along something. I had an interesting case yesterday, Jordan, and the rest. It was a 19-year-old guy, and he had a long COVID for about 14 months. And his main symptom was feeling of not being able to breathe, like he was hypoxic. And this kid was very brilliant, very smart kid. And that was one of his main things. Then he also had, of course, fatigue, and he had some arrhythmias and hypertension. Hypertension has been uncontrollable with medication. So we did an EBO2 on him yesterday, which I don't know. I'm sure if none of y'all, some of y'all don't know what it is. It's sort of like the HELP apheresis. Yeah. It's extracorporeal ozonation and oxygenation, blood oxygenation. Anyway, we did that yesterday. The kid called us today. It's the first time that his blood pressure has been under 120. It was 113 over 90 or 89. And he's not taking any medications anymore. And he's got a good majority of his energy back. So this is another thing I think we can look at in the future. And of course, this is anecdotal, one patient.
Well, but I think Risa's actually done, Risa and Jaka, they've done, we don't have it here, but it's called HELP apheresis.
Yeah, that's what I'm talking about. No, he's actually got an appointment with them, but the only place that they could put him in was in Cyprus, Greece. And he's going to actually, they still have an appointment to go there. But I said, you can save your trip because, I mean, within 24 hours, the kid has turned around and he's breathing. I mean, he feels better. His first time his hypertension has been without medications. I mean, it was running 170, 180. We're talking about systolic. So this is the first case that I've been involved with that it could be in that armamentarium with your anticoagulation therapy. So, and for people that are, younger and more active and, there may be more high risk, we could try the EBO2 on these patients because we actually did see microclots in his blood when we were pulling it off. So it was interesting. Anyway, I just want to add that, just keep that in the back of y'all's mind that EBO2 treatment may be something we'll be doing more in the future.
Yeah. And by the way, one of the surrogates that I would like to be able to have, and it would be, I still try, there's a cardiologist in England that was on the phone call with us a couple times, and it would be right ventricular pressures and right heart pressures. Cause I think these people have elevated right heart pressures after this thing. I mean, we know they all have. I mean, had a guy the other day that had never had blood pressure issues in his life, and now he's seen his cardiologist and he's on 4. And the only difference was, he'd been vaccinated. And so again, these are issues. You block up the microcirculation, you're going to have increased pressure. There's no question about that.
Yeah, the blood pressure liability is crazy. I'm going to move on in the interest of time. Real quick question, and then Dr. Corey has his hand raised. So there's a real quick question that should be easy. Claire Rogers is asking, can you elaborate on triple therapy dosing suggestion?
So what I would challenge you to do, and I can send out my little thing. I actually think Risa and Doug want a lot of what we're doing disseminated. But it's really what they did in the trial was aspirin 325 that's enteric coated. They did 75 of Plavix, and then they did direct oral anticoagulant at blood clotting dosing. So it'd be like for us to be the starter pack of Eliquis, or 5 twice a day. You might want to do 10 twice a day for the first 7. And then you want stomach protection. Now, I will say there's other things that we're looking at that at the bench seem to have some benefit. One of them being things like serrapeptase and nattokinase. These are serrapeptase comes from the silkworm. It's a proteolytic enzyme that actually helps them get out of their husk. It's a classic thing that's been used in kind of medicine for like sinus issues. It's a mucolytic. I've taken it myself just to find out what the side effects were, because I usually don't like giving it to my patients without knowing them, which I don't recommend that as a doctor, but it did dry my nose out like crazy. But of course, most people in the South with allergies loved it. So at minimum, they were like this thing works. But there's other things like that. I think N-acetylcysteine, I think Kendra Rigdon is on here, who's a biochemist, and she has a lot of information about other things that have that proteolytic activity. Because in a perfect world, we wouldn't have to stop, or what I would say inhibit, the coagulation system, but instead send in a medicine to eat up the what we would call clot buster. Get a safe clot buster would be pretty cool. So
Cool. All right, Dr. Corey, Pierre, you have.
Hey,
Yep.
yeah, no, I appreciate the discussion.
Your video's not on, just FYI.
Okay, yeah, I'm in a car. Hold on, let me
Okay,
just.
that's cool. That's all right. We know what you look like.
So yeah, and I appreciate the early recognition of the clotting, the hypercoagulability. In fact, the first paper I published on COVID was after my fourth patient I saw. We were doing TEGs on all of them, and they were off the charts. I mean, extreme suppression of fibrinolytic activity and hypercoagulability. I mean, we know that early phase in early 2020, that was the most coagulable of the variants. I will say clinically, over time in acute COVID, the clotting has been less prominent. We definitely do not see the rate, frequency, and severity of the clots that we did in the first ones.
Mine appears later, like it's like day 10 or 11.
Yeah, no, but I'm talking about in terms of variants. But I do think the clotting is huge. One question I had, so the first question I had is to Angela, which is, where did you get your TEG? Because the first paper I wrote was actually on TEG profiles of patients with acute COVID in the ICU. I mean, they were insane. The TEG profiles were just off the charts. And, when we talk about microclotting in these long haulers, and I have a practice focused on, long haulers and post-vaccination, listen, Angela has a centrifuge and a microscope, and she had access to RISA and, got to get a little confirmation there. But there's not really a standard test to look for microclotting. And many of my patients, their D dimers are normal, right? The fibrin's not being broken down. So the D dimers are normal. And, I've thought and entertained about like sending serum viscosity, but there's many different drivers of increased serum viscosity. One of them is hypercoagulable syndromes. And I just sort of want to get it. So the other thing I want to say is that in a group that I work with in the UK, they do live blood analysis where they are using dark field microscopy. They're able to grade the degree of microclotting, and we're using triple therapy to tremendous benefits. In my American patients, I have to do it empirically. I don't really have a supportive test to guide the decision to initiate triple therapy. And so, I wanted to ask Angela, how did she get her TEG? Did she have to go to a hospital? Was that outpatient center? And really what we really need, guys, is we need some sort of ability to get a sense of the degree of if I'm going to put someone on triple therapy, which has risks, I want some supportive test evidence.
The goal of
rationale to do it.
The goal of RISA and Doug actually were the inventories that we're taking is trying to figure out. I think in the end, we could, when we do the randomized control trial, you could have those surrogates that you don't even know yet might be pretty good at, predicting, so we don't know yet, but what if we could do is we could have a study where we're looking at all those things and say, hey, in the presence of this also seems to be present 80% of the time. And that's my goal as a clinician to say, we got to come up with some surrogates because not everybody can go to the hospital.
Yeah.
And get all this.
So like Dr. Corey, what I actually did is, I just was, you get on a mission and like, something's not right and I'm going to figure out what it is.
Sure.
So I contacted one of the reps for the machine and found out they had it at my local hospital that I'm on sort of semi-active staff. They don't call me much in Durham over there, but I had my partner just write an order for it. And then I walked into the lab and they did it. And I knew that, it's really quick test. So it actually, I didn't have, they billed Cigna and Cigna paid for it. I didn't have any issues with coverage, which Cigna's terrible.
So that's very helpful to know because in some of my patients, perhaps I would just write an order, tell them to go to the hospital lab, because the
Yeah.
tags are not at Quest, they're not at LabCorp.
Right.
It really needs to be a hospital. I mean, I use tag a lot in my ICU practice. I mean, we used it for, really severe and critical illnesses. It was super helpful.
Hey,
Mhm.
Dr. Corey,
Yeah.
question for you. Are you seeing when I start people on it, the first 2 weeks, I mean, these people get increased kind of feelings in their lungs, increased tachycardia. They might even get like worse cough, and they feel really weird. And it's almost like a sign that it's doing something. Are you seeing that when you start triple therapy in your patients?
What we're seeing is more Angela's story, is that when you start triple therapy, they are just seeing a mitigation of the brain fog and the fatigue. Like that.
Yeah, well,
like
the
fatigue
brain
thing-
fog they get better on, but what I'm saying is like these people that have just nasty chest X-rays full of just crap from like
Well,
years.
that's more acute. Like the patients
Well, these
that
people
I'm
had
seeing
had COVID. They had it 18 months ago.
Yeah, I mean, I don't see people that have normal X-rays 18 months. Most of the patients they do not have like pulmonary predominant problems. They have constitutional issues, which is truly the long haul and post-vaccine syndromes, which is a constellation of symptoms, many of which you mentioned, right? Which is, fatigue and brain fog and the tachycardias, the POTS, the orthostatics changes, tons of neuropathic symptoms.
My initial ones, a lot of them were like college swimmers or people like that all they did was ever test positive for COVID. And then you get their chest X-rayed and they might as well have gone to the hospital compared to the 60-year-old. Okay. They just had huge reserve. Okay. And then I'd treat them, meaning their chest X-rays and their CT scans, they've got interstitial changes and even ground glass opacities, but they're college swimmers, And so I think there's a ton of that burden out there.
Yeah, I mean, I think that's a different kind of patient. Most of my patients, they've been sick for a long time. They've been through the system. They've seen many specialists, gotten lots of tests, lots of referrals, no therapeutic trials. And I see tons of normal CAT scans. Most of what I'm treating is not pulmonary predominant.
Do you use those? Did you see the Italian, they did that SPECT CT? Have you seen that? The perfusion CT?
Yeah.
Have you ever done that in them to see if they actually have good, even their CT scans are normal, their perfusion's abnormal?
No, I haven't done those, because I will tell you, pulmonary limitation or exertional tolerance is not really a predominant symptom in the patients that I see. Okay. I mean, I see just a huge diversity and array of symptomatology. Lots of it neuropathic, constitutional, fatigue, cognitive, brain fog, things like that. I'm not seeing people with like what I would call pulmonary predominant symptoms, things that limit them in terms of their respiratory function. I mean, some of them have it, and it's hard to tease out from all the other things that they're seeing, but the patients are really complex and they have a wide array of symptoms.
Yeah, no, I agree. I think I got involved, unfortunately, and a lot of my patients, if they're college athletes, they talk. And what I mean is, they've had these issues, they've seen everybody. And so I'm seeing a lot of very fit people that used to run a mile time of this. And, now and there's no other difference that's happened other than they had COVID. And they have
that's a different type of profile of opinion, and that I would really want to be interested in. What is limiting them in a pulmonary physiology? What is their pulmonary deficit? Certainly, as you showed and as we've seen, I mean, the microclotting in the lungs that would be one of the pulmonary limitations, and it's not being picked up on CT scans. Yeah. And that's why I was talking about, like, I wish we had some more readily accessible test which could support us in anticoagulating, because
Angela, what was Jaco talking about? The pulse test? He's got some tests that looks at endothelial activity.
Yeah, the pulse test, from what I understand, is it's more of a marker. It's a predictor of cardiac events. I don't know that it would.
It's not the pulse. He had some kind of electrical. Anyway, again, South Africa is just so much different than us, I guess. But he had some way to tell the endothelial. It was an electrical test that told how the endothelium, and he actually was pretty confident that it worked. He's trying to do studies on it. But
I'm interested in anything that because here's the thing, like everything that we're doing, right? We're out on the fringes of medicine. We're not being supported by the system. There's no real good studies on vaccine injury. In fact, vaccine injury isn't even a thing, right? Yeah. I mean, there's no vaccine injury.
That's why I call it spike protein injury.
Yeah, and by the way, I want to commend you on that, because that's something that Paul and I have been talking about, is that, you know, the central underlying problem and why so much of the system doctors are lost is they have not understood or been taught that the spike protein is a pathogen. It incites a number of mechanisms, which contributes to a complexity of disease. And if you don't have that conceptual framework, it's like you said that so well. When I see patients, the first 10 minutes, and I spend a lot of time with them, is them regaling me with their journey through the system, and this specialist and this specialist, and you know what they're doing? They're doing exactly what you say. Those specialists are trying to fit them into traditional diagnostic categories of diseases they know and mechanisms they know. And they have no idea that it's the spike that's manifesting itself in pathologically in numerous ways. And I feel bad for our colleagues, sort of, because
if you don't understand that, you're going to miss it.
Exactly.
And
that's why I've been saying, like, we need a new almost medical discipline, which is a specialty focusing on spikeopathy, right? On what spike protein does to the body. We need to enumerate all the mechanisms and all the therapies that counteract those. And I think your work and your insights are part of it. You know, it's not all clotting. I think it's so complex and there's numerous mechanisms, but
I think
there's
inflammation
a big
too.
one. It's a big one.
I think there's no question that I've got patients that, especially ones that have underlying autoimmune diseases to begin with, there's, you know, they have the inflammatory side. You can't just treat one.
Yep.
And I think
you're absolutely right. It's super complex, and I'm constantly humbled by patients. I mean, some patients I treat with things, they respond so magnificently, and then I try the same thing on a patient who appears similarly clinically as far as history, and they don't respond. And so I'm constantly like I feel like I'm swinging in the dark. But
have you done genetics on anybody? Have you done genetics on it? What I would call,
no.
I feel like there's this hypercoagulable, this genetic predisposition that would be, I mean, it's
you know, I wish I could have more of an organized ability. I just have so many patients who are so sick, and I'm just kind of evolving and learning. And, you know, like, for instance, like a talk tonight, listen to you guys. And one of the reasons why I'm on is because I've been like really interested in the microclotting aspect, because of the things that I use that works the most, you know, at the tops are, for me, ivermectin, low dose naltrexone, hydroxychloroquine's kind of a distant third. And now I'm starting to see that the triple therapy is really profound as far as really helping patients. And so I'm kind of looking for the big guns. And I know that anticoagulation is a big piece for a lot of these patients.
What we hope to do, if I get the funding, would be a randomized controlled trial that's a 3-month crossover.
Yes, crossover, absolutely.
And so I think you would, you know, I would not know what I'm giving them. Risa would read the labs independent of me, you know, and we would do it, and then 3 months it would switch. I think that
and crossover is the most ethical, right? Because they're suffering so much.
They feel crappy
so long. Yep. Absolutely.
I can't. We couldn't do it. I don't. You can do it just straight out placebo trial. I don't think that.
No, not with these patients. I would never do that. I mean, I couldn't see a patient and enroll them into a placebo trial, but you know, I could easily do a crossover where we're really, because the patients also want to, you know, these patients are so sick and they want to help. You know, they're
like, tell my story.
Yeah.
And not only that, I give them Risa's papers and stuff. And a lot of these, by the time they get to me, they've seen so many doctors that they want to send those papers to those doctors. And I encourage them to do that. I'm like, here's the paper, give it to the doctor. If he reads this and doesn't at least go, that explains a lot, you probably never want to see him again, but but he probably will.
But again, if they don't have that conceptual framework that this is a spikeopathy and a spike protein mediated disease, I don't know that one paper is going to turn them. You know, they have to understand that the vaccine is a toxic, you know, is a pathogen. The spike protein is a pathogen. And until we organize our thoughts and our conceptual framework around that, you know, we're going to be flailing.
Well, I think that's what Doug and Risa did so well in their papers, is they didn't say vaccine. They just said SARS-CoV-2 spike protein S1.
Smart. Yeah, you're never going to get far calling it the vaccine as the pathogen. So you're right. Absolutely.
Yeah, but when you read it, you go, guess what the vaccine makes? You know.
Yeah.
Right. I'm going to have to jump in here, guys.
Oh, sorry.
Yep. We have one more. Thank you, Dr. Corey. I'm going to lower your hand down. There's another question here. Thank you. Ryan, you have your hand raised.
So I just wanted to say, I echo the one who said that the ozone was helping. I've been using ivermectin, some antiplatelet therapy, not really prescribing, but using pycnogenol. I'm also used some Beloc or a lumbrokinase. And then we use 10-pass ozone. So similar to what he was talking about earlier, where we take out blood, ozonate it, and then put it back in. And I think I just asked my staff, I think we've done about 7 of those. I would consider those long haulers. All kind of symptoms, just really just sick, but hard to really put in any kind of box. And we don't tend to do that anyhow. Just fatigue and some with clots. Saw a guy today, he's had 3 clots in separate limbs, 3 CVAs, an MI, had never missed a day of work for 40 years prior to the vaccine. And we did 10-pass on him. He had one of his arms was kind of blue and just sluggish, not a lot of sensitivity. We did just 1 pass on him and already saw change. The pulse ox was like 70 when we started. By the end of it, he was high 90s, and that stayed. The next time he came back, it was high 90s. That was really an amazing case. So antiplatelet, ivermectin, and then ozone has just been just fabulous.
The other thing is one of the other point what I want to make is just like that guy that I had that had COVID, parents came home, had leg drop 10 days after being diagnosed with COVID. Obviously I would treat him as a stroke as well, but that I've also had a lot of people that literally, they get infarcts in their, optic nerves or even, abducens, or they get a lot of weird stuff. They'll go to the hospital, they'll work them up to find where the hell a clot is. Okay. And they'll spend 3 days in there and no one will find anything. And the ophthalmologist will be like, we don't know what caused it. And then they'll come to me. Interestingly enough, I will do, as if it's because usually they had a booster recently or something like that. And we do this and their vision returns. So again, we're talking there's other things we do before we pull the trigger, meaning MRIs, those kind of things. But it goes to the thought that, people are losing vision because of lack of knowledge, which is, like Pierre is saying, that's the biggest bothersome. This ophthalmologist finally said, you know what, you're right. It is the clot is from the booster. Of course, they've searched everywhere in his body for a clot, but it just shows you that the knowledge needs to be, I don't know how to disseminate it. When you got a guy like like Pierre or anybody like that, or the head of cardiology at Harvard writing papers that say this is a vascular disease, I don't know why that's not being put out by the bigger organizations.
Yes, you do.
I know.
You
okay.
do.
I know.
Okay. There's another quick question, and then I think we're going to wrap here soon because it's 20 after 8 here in New Jersey, and I haven't had dinner yet. So there's a question here from Dr. Tank to Dr. Corey. What percentage of your spike protein injury patients don't have fatigue or fog? Either of you guys can answer that.
What percentage don't have it? Very, very, very few.
Yeah.
For me, the cardinal symptoms of long haul and post-vax, the most overlap is the 3 cardinal symptoms are fatigue, post-exertional malaise, and brain fog. In the post-vax, I see way more neuropathic symptoms like Angela talked about, small fiber neuropathy, motor dysfunction, tremors, all of that. But yeah, no, fatigue is almost the cardinal symptom. And then post-exertional malaise is either a close second or right up there.
Pierre, what do you think about Kell's kind of chronic ischemic reperfusion concept that's going on that's causing that fatigue?
It's certainly possible.
The microclotting of it, and then you get the reperfusion injury because it gets limited, needs more blood. Then
I still think so. Here's the thing, when you look at Paul Marek, right? He's done like the most comprehensive scholarly review of the possible mechanisms, right? That's on our website, and Paul's done such a great job. He's reading everything. There's probably like 5 or 6 different mechanisms, and where I'm humbled is that in the individual patient, I don't know what the predominant mechanism is. I've had patients have phenomenal responses to ivermectin only. Yeah. And then others have nothing to ivermectin and they respond to other stuff. And so it's still kind of like a swing and miss type thing. That's why we do trials of therapy. And
again, we don't have appropriate testing. We don't have a good testing algorithm to kind of identify like which is the predominant mechanism. And so it's frustrating, but you know, I keep trying and the patients are getting better. Sometimes it takes me more tries than others, but you know, the anticoagulation thing is the one where like I've just struggled because it's the only thing that I do that would have potential risks. You know, everything else that we use is so safe that like I'm pretty confident with therapeutic trials, whereas anticoagulation, you know, I just get worried that, you know, I don't want to have an accident. I don't want to hurt someone.
Yeah.
So anyway, that's what I got to say.
I guess that's why you have to be very select in the patients. They're not typical of your ICU patients.
If I get if and when I get this funding and I get, I want to get on, I'd love to get on the phone with you and Paul about what kind of, I mean, basically we would have a whole armamentarium of what we want run on these people in the trial. And I think it would give us a lot of secondary endpoints, like meaning finding out.
Yeah, let's talk.
Yeah,
I can hook you guys
Let's
up.
talk. Yeah.
I have a dog. I just want to thank you. Yeah, it's my puppy. I want to thank everybody in the interest of time. I mean, we're already over time, but this was a really awesome discussion. Jordan, thank you so much. Angela, thank you so much. I really appreciate your input and your knowledge, and I'm going to put you guys in contact with each other. I'm going to give a little closing announcement here, and this will go out later as well. I'm going to be changing the time. Dr. Corey had suggested when I met him in Florida, and it is absolutely true. You know, Thursdays we're going right up against Steve Kirsch. He's on at the same time, and you know, he's got some really important information out there, and everything's being recorded, but you know, there's nothing like being there live. So I do have speakers who are booked through September. In the beginning of September, our last Thursday will be at the beginning, and that's going to be with Dr. Bean. And then we're going to start on Tuesday evenings, September 20th. And that's going to be with former Assistant Attorney General Maureen West and Attorney Tom Renz. It's going to speak about some medical freedom and all that kind of good stuff. So come September, we're changing to Tuesdays. But until then, we're going to continue on through August. Our next call coming up is going to be with Dr. Suzanne Gazda. She is a neurologist who's going to talk about some pediatric stuff and some brain fog issues with long COVID. So I thank you guys all very much for being here. I'm going to end this call. If there's no other questions, I will say good evening and God bless you all. Thank you again. See you next time.